So what's transference? We talked a little bit about this: displacement or projection of patterns of relationship, attitudes, feelings, thoughts, etc., originally experienced in early childhood relationships with other people, which we have the technical jargon objects for, use the word objects. And these are this is like in adults in your adult life. So the idea is that you have this relationship when you're a very small child, and that relationship takes on a certain pattern, and that's the pattern you know how to relate to other people through. And in normal development, that pattern gets modified into a mature pattern. You go through all the different stages, and then you know how to relate to other people. But if you have a pathology, that pattern may get stuck in whatever was going on when you were an infant, and you'll use that same pattern when you were an adult. Or, maybe it's when you're, 4 years old and you have an Oedipal complex, and that's the pattern you're stuck in. Then you use that pattern as an adult to relate to other people. And so we all do transference. It's normal. Our adult normal patterns are transferential. We're all doing transference with one another. I think I mentioned this last time. One of my great things that I'm trying to promulgate is this idea of dominance, hierarchy, confusion, trademark, which is the idea that we're in so many dominance hierarchies. We're in so many transferential patterns with so many different people that we become very confused. And this is part of where at least our neurotic illness comes from. Our higher level illnesses come from. So I wrote about that in the new book, so I'm not going to go into it here. But just so that one of the problems is that, in traditional, human society, you would only been dealing with maybe, 30 to 50 people your entire life. And now we literally deal with thousands and hundreds, and, we go all over the world, we move around. But our psychological mechanisms have not, our evolution of our psychological mechanisms has not caught up to our modern lifestyles. And this may be something that causes problems, though we are adaptable. Obviously, we're able to adapt to a certain degree, some people better than others. But it's been talked about that some of the mental health issues that we have nowadays may be due to the fact that some people aren't able to be as adaptable to the modern world situation that we're in. And so our transference patterns are, maybe have something to do with that. When you are doing therapy with somebody, and we talked about this last week too, I believe, there is definitely always transference, at least in the opinion of psychodynamic psychotherapists, always some kind of transference going on. We think of the therapy relationship typically as a transference heavy relationship. It creates a kind of a petri dish for the transference to really show itself, especially when the therapist maintains their neutrality. And we'll talk about neutrality in a minute, but that's a very important thing for psychodynamic therapists, to maintain neutrality. And there are different types of transference depending on the level of pathology that a person has. Earlier levels of pathology will have a more transference that will include more of the primitive defenses like splitting and dissociation, things like that, because that was part of the early relationship the person had with the parenting figure. Okay. All right. They used to believe in psychoanalysis that people with more severe mental illness wouldn't develop transferences that could be worked with. And we know now in psychodynamic psychology, that's not true. We work with everybody, including psychotic people. I think I mentioned my dad worked a lot with psychotic people, people at the personality disorder level. All those people get worked with, but they have different kinds of transferences. Okay. Transference relationships are unconscious and repetitive. They occur repeatedly without us becoming aware of it. So we're doing transference all the time, but most of the time we're not really aware that it's a transferential relationship. This is one of the reasons, and I'm going to beat this dead horse all semester, so just get used to it. This is one of the reasons, as a therapist, you need to go through your own therapy process. Because in therapy, when you're doing therapy with people, you need to be conscious of your transference. You can't be, our day-to-day life, we're unconscious of it. I go to the grocery store, I go to Whole Foods over there, the cashier reminds me of my dad, I have a certain kind of like reaction to him. I buy my food, I'm on my way, I never think about it, right? But in the therapy office, you got to be aware of it because this is where therapists get in trouble, both technically where they're not helping their patients anymore, and also personally where they start having boundary violations. Usually boundary violations in therapy by the therapist are usually can be related to countertransference, the transference the therapist has in reaction to the patient's transference. And so it's very, very important that you are not unconscious about your own transferential patterns. And I would say, and I'm a little biased about this, I would say it doesn't matter what kind of therapy you're doing. You could do, Skinnerian behavior therapy. There's still going to be transference, and you better be aware of it, or you're going to get in trouble. Okay? And I will beat that dead horse. I will continually beat that the whole semester. So sorry. I'm going to apologize in advance. Okay, I talked about personality organization. That we're going to talk about that later. That plays a big role in the type of transference. There's briefly, you can have a transference neurosis. That's more like transferences that typically are related to Oedipal complexes. Borderline transference, that's more at the personality disorder level. Narcissistic transference also at the personality disorder level, a little higher level than borderline. We're going to talk about all these. Or psychotic transference, where the person's very, very fragmented. And the resolution of these transferences can lead to positive structural changes in the patient's mind. It can help them either get their personality adapted to their situation or to help them rebuild their personality and restructure their personality to something more useful for them. Okay. All right. I think I said the other stuff already. Any questions on any of that stuff so far? Does that make sense? Yes.
So transference is like the words to how to change the personality.
You will work as a psychodynamic therapist, you will work with the transference, mostly through interpretation, but also just by being a neutral, warm, consistent presence. The person can bounce all their crazy, they're trying to recreate the relationship from their early childhood with you unconsciously. But when you don't buy into that, you just remain neutral and warm, then what happens is that person then learns a new way of relating. And then the idea is that becomes a corrective emotional experience. And in the kind of transference they do, then becomes more mature. It evolves into a more mature way of relating to people. And you'll see this is talked about in all different kinds of therapy, right? So, but they won't necessarily use the same language. They'll just say, oh, I went to the therapist for, I was going to started therapy, every time I had a boyfriend, I picked this kind of guy, and this guy was always horrible to me. But then, after I was seeing my therapist for a couple, for a year, I started picking guys that were nicer to me, and I realized that my therapist was a nice man, and men could be nice. And, I learned how to relate to a nice man. And, that's a kind of a lay person's way of explaining this stuff. But people talk about that all the time. And you can just turn on TV therapists, they'll talk like that, right? But what they're really talking about is the transference, change through the relationship with the therapist. And remember, this is another dead horse I'll beat a lot. It's the relationship that heals. Okay, it's the relationship with a consistent, warm, neutral, non-judgmental person with unconditional positive regard in the Rogerian language for the client, for the patient. And the experience of that over time can change the way the person unconsciously relates to other people, and consciously as well. Does that make sense? So that's why it's really important for therapists to remain neutral. And this gets into all sorts of therapeutic technique, like how much do you share with your patients about your own life, your own situation, it gets into that. And that is something we'll talk about in a minute, but that's something that can make a big impact, because that warm neutrality, where you are just like a blank movie screen, you're like this screen here, blank, that the patient projects their relationship stuff onto, and then, you learn how to interpret, you can reflect that back to them in a way that's not distorted by your own stuff. It's the getting distorted by your own stuff is where the problems start. That makes sense. We'll talk more about that. Okay. Let's see. All right. I think I talked about most of that, and we'll talk about interpretation. At a certain point in the therapy, you will start interpreting what the transference is, what the patient is doing to them. And that that will help the patient become more consciously aware of their transferential patterns. That just takes time and repetition. So that happens over and over and over and over and over again in therapy. Okay. Person comes in and it's like they're, you're the therapist, say you're a male therapist, they come in and they're like, wow, I tried to call you last week to get another appointment and you didn't answer your phone, and you might say, I wonder who else, I wonder if I remind you, if the fact that I didn't pick up the phone reminds you of somebody, and the person will go, oh yeah, my dad never responded to me, and they'll relate it to something in their past life. And they'll say, yeah, and I had to like bug him and yell at him to get him to talk to me, oh, okay, well, maybe that's what was going on last week when I didn't pick up the phone, right? So you bring that, you help interpret the transference and help the patient see how the transference being acted out in the office with the therapist. And then later on, also, you'll see the person will bring in situations in their life and they'll start to see how the transference is being acted out in other places in their life. But sticking with the therapist is the place to begin with, right? That's the place to begin with, because that's where it's going to be the heaviest and the most present, because it's in the moment. But later on, things from the person's life will start coming in. And when the therapy is doing really well is when the patient will come and say, oh, I went out with this guy last night and guess what kind of guy I picked? I picked a guy like that. I should have known better, but I realized that halfway through the date, I'm picking a guy like my dad was when I was 2 years old. I realized it halfway through the date and I left, whatever it might be. Patient will start interpreting to themselves. They'll start internalizing your message to them. They'll start internalizing that, and then they'll be able to do it for themselves. And that's telling you somebody's making progress when they're able to do this for themselves. Okay. Also, something you'll see in TV therapy, lay therapy, people will talk, again, not using this language, but they'll talk like that. I realize my pattern, whatever it is, they'll have a kind of a lay, non-technical word for it. Now, in CBT, you probably talk about thought patterns, and thought patterns can be part of the transference. But I will say what's really important, at least in my experience, not just the thought patterns, but the emotional patterns are really important. The emotions that are attached to the behaviors and attached to thoughts, really, really important. And what I might do if there's a client and they're having a transference thing, rather than interpreting the transference directly, I might say to them something like, what emotion are you feeling right now? And just really get into the emotional state, really explore the emotions. And then later on, tie that into the transference more explicitly. I wonder if this emotion reminds you of, of a certain age that you were, how old do you feel you are right now? Oh God, I feel like I'm 4. When I was 4, this happened, and the person will have a memory and they'll be able to start fleshing out the transference into consciousness. Okay. But when the person starts interpreting for themselves, that's when they're really making progress. All right. All right, we talked about this. And neutrality. Okay, neutrality, the main point of neutrality is that the clinician does not react to the transference pattern in the same way as the significant people in the patient's past. In other words, especially when that way of interacting with people in the past doesn't serve them as an adult, right? You had a borderline, parent, and, they gave you this, and we'll talk about this more later too. They gave you this sort of pattern of relating to you, which was, I hate you, don't leave me. That's a typical kind of borderline pattern. And that's what you've internalized as a child, how you relate to people as an adult. You're super aggressive to them, but then you're super needy and clingy at the same time. I'm sure none of us have had any relationships with romantic partners that are like that, right? A little clingy, boyfriend, clingy girlfriend, but that's a pattern. Well, that doesn't work as an adult. It's not a very, very satisfying pattern as an adult. And so if the person, then if you are the therapist and you maintain neutrality and you don't react to that pattern in the way the person's trying to get you to react the way their early childhood figure reacted, because that's what they're comfortable with. That's what they know. When you don't react that way, then that can open up to starting to learn something new, a new way of interacting with people. It can also scare people off when you don't react the way that they expect people to react to them. And this is why you have to build up this therapeutic alliance first. You have to be maybe a little more supportive in the beginning. And then as time goes on, you can start interpreting transference. You wouldn't interpret the transference right away. You got to wait. because otherwise that could scare people away. You do it the first session, person's not going to come back, right? But you wait till you build up that therapeutic alliance, you're aligning yourself with the rational part of the person. This is a little CBT like, you find the rational part of the person, that's who you're trying to, establish a relationship with, because that ego part of the person, that's the rational part that will bring them to therapy, that will not blow through stop signs when they're driving. That's the part you want to develop a therapeutic alliance with. And then you maintain neutrality, then you can start interpreting transference, a little bit later. Okay. So consistency is really important. You have to be consistent. This is sometimes hard to do if you're a therapist and you're traveling, or you have a lot of things going on. Maybe, I know therapists like this. A lot of therapists nowadays have very busy lives. They're traveling. They are, one of my friends is on TV a lot. People are doing different things. They have 5 different jobs they're doing for different places. And then it ends up where like they can't make a session, or they have to change the time. And that doesn't work well for psychoanalytic psychotherapy. It really works well to be a very consistent presence. Can you be a consistent presence and be doing all these other things and, changing your time schedules and things like that? Yes, you can do it. It's just harder. Just makes it more difficult. But the consistency is really, really important, because probably one of the reasons people come to therapy is because their early childhood life, there was not a lot of consistency from their parents. That's a typical thing you'll find when you start talking to people and they start telling you about their past life. There a lot of times, and the more inconsistent the parenting, the worse, the more severe the pathology. Okay, and we'll talk more about that later too, and expand upon that later. But that's pretty typical. People come in, and you'll see then the inconsistency they had in their childhood. You'll see the inconsistency in their current relationships, and you'll see them maintaining the inconsistency, them showing up late, them not going to work, them, getting drunk and taking the day off. All those inconsistencies will play out in their own life. And so the therapist has to be extra consistent with them, right? And then that changes the dynamic, changes the pattern that they're used to. And then the therapist doesn't react when they try to pull for the pattern that they know. Therapist doesn't react to that. Therapist just reflects that. Sounds like you're trying to make me into your mother, something like that. Starts interpreting that. And that over time, again, the repetition of that consistency over time is what helps the patient to heal, to change the way they relate to other people, and also to change their understanding of themselves. So very, very important. Neutrality is very misunderstood. Now, all those things I just said are much more difficult for personality disorder patients. It ramps up the difficulty 20 times. You could be the most consistent person in the world, and because these are people who typically had very, very inconsistent childhoods, they really, really will go out of their way to push your buttons to make you inconsistent. And that's one thing that really is difficult about seeing personality disorder patients, especially cluster B patients. Borderline narcissistic patients are really difficult to work with. And obviously, antisocial personality disorder patients, sociopaths, psychopaths are difficult because they're just doing their own thing. Right. We're going to go more into about them, but the cluster B patients are really, really dramatic, right? They're very difficult. And so that becomes maintaining consistency becomes much more difficult. Psychotic patients, this really depends a little on your personality. I never had any problem with psychotic patients. They're so dissociated and fragmented that it was, even me being, a little inconsistent in my life, compared to them, was so much more consistency than they were used to and was going on in their own minds, because they're inconsistent with themselves. So, I never had any problem working with psychotic people. Always seemed, much more comfortable to me. And then the fact that you're there every day and your consistent presence can make a big difference, even if you're working in like a mental hospital, like I did, like I could be a consistent presence, You know, Marion would come in every night and tell me she was going to cut my balls off, you know, and that was her way of asking for a cup of coffee in the middle of the night. It's like, okay, you know, and every night she'd come over and, you know, get you coffee, you know, very consistent relationship. She, and that kept her calm, that kept her together, you know, just that simple act of like interacting, giving her a cup of coffee, being nice to her, being supportive in this way, you know, night after night after night after night, you know, she was very mellow. She mellowed, and didn't have any problems with her, right? As were other patients, you know, that was not the case. You know, so again, even with psychotic patients, consistency is important. It's not necessarily a verbal, you know, with higher level, you know, patients, you know, you're doing a verbal, dare I say, they use the word game. You know, therapy is kind of a verbal game you're playing, right? A lot of psychotic patients, you know, a lot of the verbal stuff just gets acted out. And so it's really more behavioral. What are they acting out? You know, maybe hearing voices or something, but they're acting things out. And so you also act out the neutrality and the consistency, not just with what you say, but also what you do, who you are, how you present yourself. All those kind of things are very, very important. And, you know, again, psychotic patients, you know, in some ways it's a little easier. For some people, though, the dissociation, the fragmentation of the psychotic patient's really difficult for them to deal with. And that'll depend on your own personality. For me, that was not, I never had a problem with working with psychotic people. Some people really, it's very difficult. And I know people who've gone and worked with psychotic people and after a week just said, I can't do this, and then left. And yeah, it just depends. But I'd say everybody has a hard time working with, most everybody has a hard time working with personality disorder cluster B patients. They're difficult, except for my supervisor who loved working with borderline clients. That was his favorite. You know, he loved it. He'd love to have borderline. Yeah, it's great. You know, he just loved it. That was his thing. But he's probably in the minority of clinicians, right? And also, you know, one of the big things, and again, I'll talk about this in more detail later, but you know, getting some training to work with personality disorder clients, very, very important. So, you know, it doesn't matter what kind of therapy it's DBT or it's a CBT working with personality disorders, or it's psychodynamic, any of the psychodynamic therapies, and there's a bunch now that are focused on personality disorders. Very important to get training, because again, all this stuff is going to be more difficult. All this transferential, countertransference, neutrality stuff is going to be more difficult. And all right, two types of transference, positive and negative. Positive, the patients project their idealization of their early object of their parents. You know, when you're little, your parents are like gods, you know, and you idealize them. And so they project that onto the therapist, and they develop these strong feelings of love, even sexual attraction, because now they're adults, they're not kids anymore. So they have, you know, functioning, adult sexuality. And you know, the early love then gets translated into this erotic love, because, you know, as they become adults, so they project that onto you. This is also really important, why you need to have your own countertransference stuff, you know, in check, because this is where therapists get in trouble. And I'd almost say, I may be wrong about this, but I'll put it out there. You can tell me if I'm wrong, but the positive transference in some ways is almost more dangerous than the negative transference. You know, you're a therapist, you live this lonely life, you're just seeing patients day in, day out, you have no social life, you have no romantic life, you know, you have these patients come in, they just, you know, you're unconditionally good, they just love you, you know, like you're perfect, they eroticize you, you're so beautiful, you know, all the things they tell you. And then after a while, you know, it's like, okay, you know, you're not aware of your own reactions, your own needs, your own transferential things going on. This is where you get in trouble. I actually think the positive transferences probably causes more trouble for therapists than the negative. The negative is like, okay, the negative transference, you know, patient becomes critical, resentful, hostile, aggressive, all the negative feelings they had toward their early parental objects now come out, right? All the frustration, all the things that they had, that now comes out. And depending on the level of their personality organization, will come out in different ways. But that comes out, but that's generally like, you know, okay, they're yelling at me, you know, they're mad at me, you know, yeah, okay, we can work on that, you know, we can work with this, you know, I'm not going to get in trouble over that. very rare you find the therapist that will, like, somebody, patient comes in, it's hostile to them, and they'll just, whack them across the face, slap them into submission. That very rarely happens. I would say probably the sexual misconduct happens more than the violent misconduct. I may be wrong about that, but that's my general impression over the years. You don't hear too much about therapists beating up their patients. You will hear about patients beating on their therapists. That does happen. I think, I can't remember if it was this book or the other book. My dad had a case where one of his patients hauled off and hit him. Really autistic guy. Interesting. And then that was the breakthrough though for the therapy. And my dad remained neutral. He fought off getting beat up, but he remained neutral. And then he interpreted the transference after that, what was going on. And the guy, like, that was the breaking point where he opened up after that. I think that's in the book. I can't remember if that's in this book or the other one. It was a really interesting case. Yes.
How like positive transference might get you into trouble, like.
Oh yeah, of course. I mean, look, if somebody comes in and idealizes you, they're coming in week after week after week, and you are just the most beautiful, fantastic person in the whole world. You're just you're helping me so much. You're the best therapist that ever lived. Like, oh, you're just like a saint on this earth, and you're just hearing this over and over and over again. And you have unfulfilled needs of yourself because you have not dealt with your own issues. Now you start having transference back toward this person. They become that father that was never there for you, or the mother that was never there for you, and then those become, also because you're adult, those become eroticized. And then that's when, and I think I'll show you in a minute, the results, what happens with that. But yes, that's that problematic. Very important to know thyself, right? Very, very important as a therapist. Right? Yeah.
Started like, oh, you're best.
Yeah.
And I was like, yeah. Now, like every time she's like, I just wanted to let you know you're really good at being really healthy,
That's exactly.
So
that's this.
Like, should I be concerned?
Warmly neutral. Just warmly neutral. Later on, if you develop a relationship with this person, I don't know how many sessions, it'll just depend, you feel like they're really locked into therapy, they're really committed to therapy. You might say, it's interesting, you come in and you have all these great feelings about me. I'm wondering if there's any other feelings you might have. Because you might also explore the fact that she has negative feelings, but she's covering it up by saying all these positive things. That's another thing that'll happen, right? They'll use it defensively. Right. So it could be positive transference, but the negative will come out eventually. If you see her long enough, the negative will come out. And usually the positive will, I should have said this, the positive usually comes first, right? Can come on very early on in the therapy, and then the negative will come later when they've established a relationship with you and they trust you enough, then they can express the negative transference. Now, that's not true for borderline patients. They'll just flip-flop back and forth right away. They won't wait. But your standard neurotic patient, they'll wait till there's enough trust built up, and then they'll express the negative thing. And they might start out gingerly, and then say, well, I have this complaint, and they'll bring up the negative stuff. And again, you have to be warmly neutral about everything, not apologetic, not trying to fix the problem, just listening to them, warmly neutral way. And again, that's something that takes practice and supervision. Okay. It doesn't come naturally to most people. But most of us are like, we want to get in, we want to fix people, we want to help, it may help a little bit to be introverted more than extroverted. But there's plenty of like really fantastically great analysts who are very extroverted. So it's not necessary. It's just a matter of it's just a way of learning. It's a therapeutic technique. Neutrality is a therapeutic technique. And you want to be able to turn it off when you're with your family. By the way, I can say that as the son of a psychoanalyst. It's really good if they could turn that off when they're dealing with their family. Sometimes difficult, and this is true for all therapists, by the way. Sometimes the therapy switch gets stuck in the on position, and you're dealing with your spouse or your kids, and you're still stuck in the therapy position. And if you don't have family members that'll call you out on that shit, that's not good. You want them to say, Mom, turn off the therapy switch now and just talk to me like a human being. Right? Okay. You know, oh God, I gotta turn that off, you know, leave that at the office, right? Comes hard. It's a difficult profession, right? Difficult profession. And I'm sure CBT has its own version of that, right? You're probably coming in talking about people's bad thoughts, like your kids. Oh, you're thinking bad thoughts. You need to think better thoughts. Kids are going to, you know, will have none of that, right? You know, hopefully they'll call you out on it. They'll feel safe enough to call you out, and you can just turn off your therapy switch. Very important. All right. All right. So negative transference, positive transference. It can alternate between positive and negative. That really happens among borderline patients. They will alternate sometimes really rapidly, sometimes not as rapidly. You'll see different people, you know, the rapidity of how they'll flip back and forth. My experience was, I know people had experience with borderlines where they would even flip back within one session, they would go from good to bad in one session, flip flop back and forth between positive and negative. Mostly my experience was that sometimes it would be within a session, but more rarely, more like one session they'd be all positive, another session they'd be all negative, and they flip flop back and forth from week to week, and you never knew what you were going to get. You know, you never knew which side of the split you were on. And then sometimes I had one patient who would dissociate almost into a psychosis. That's another thing. Severe borderline patients can dissociate into a psychotic, kind of quasi-psychotic state. They can also pull themselves out of it too. When my patient, I would tell her, you know, I think we might need to go to the hospital. You sound like you're psychotic. Oh no, I'm not going to the hospital. Pull herself out. And she wasn't faking it. That's the thing. She wasn't faking it. But you know, very interesting. And we'll get in more detail about borderline patients when we talk about them. We'll have a whole session on them. But again, that's something you got to be this going back and forth between positive and negative. You know, it'll flip flop back and forth, even with neurotic people. Okay. See case example of transference. And this might be worth talking about. I had a woman who I was seeing for psychotherapy, saw her once a week, and one of her big problems, her presenting problems, she had a really difficult time with her coworkers, and they thought she was somewhat aloof and kind of like, you know, looked down on them. But she had a male boss, and she constantly sought out his attention. And it got to the point where he would be avoiding her. He would like leave the room when she would come in, he would avoid her. And so when she couldn't get her attention, she would call in sick. She'd call in sick. And apparently in her job to call in sick, she had the supervisor had to talk to her. She had to get let the supervisor know. So he would talk to her. And then he was keeping track of her absences, and he, you know, would make her get a doctor's note after a while. And it started becoming a problem for her. Work was really becoming a problem for her. She was thinking she's maybe going to get fired. And this set her up in kind of a panic, and she, you know, freaking out. And then somehow she got into therapy. Somebody told her you should go to a therapist. So I was seeing her. She had grown up. She was the middle child in a large family. She had a bunch of brothers and sisters. And she revealed during a therapy session, not right away, it took, you know, maybe a month or two, she started talking about how when she was a kid, her father worked long hours and she didn't see him very much. But if she got sick, the father would, you know, take off from work, come home and take care of her and give her attention, and also give her attention to her and not to her siblings. She would get the sole attention. So what did she learn? And if you're a behaviorist, she would say she was reinforced for being sick, right? She got reinforced for the gain from the sick behavior. And so during individual sessions, I would notice that she would become somewhat cloying and annoying in her behavior. And she would make me dread. I kind of start dreading her coming out. She's going to be this annoying, clinging person. It's kind of, you know, like I have to deal with this, like, you know, I dread it. And she also was in a group therapy. We also did group therapy with her in a group of women. And I had a female co-therapist. And during group therapy, she felt the other group members received too much attention. She would call in sick for subsequent sessions for our group. And, you know, she had an excuse, well, you know, I was sick at work, so I couldn't come into therapy tonight. And then when she'd call in for sick for the group sessions, what she would do is she would call me call me from her house. She called me, from home, want to have a session on the phone. This is back in the day before teletherapy, right? And so she'd want me to call her, and I'd call her back up and have the session on the phone. And after a while, I realized these sessions on the phone were pretty much like the conversations she had with her boss at work, right? Pretty similar, like, well, you need to come into the individual session, you need to come into your regular therapy, you need to come to group, oh, I hear you're sick, but it's really important for you to come to, that kind of stuff. And basically what she was doing was she was doing a couple things. She was basically recreating that relationship with her father, and the sort of Oedipal relationship with her brothers and sisters, the competitiveness for the father's attention. She was recreating that with her boss, and then in therapy, she was recreating that with me. And she used something that we call projective identification, as she projected qualities on the therapist that made me feel and behave the way her rejecting father and the rejecting boss had done. And that's what projection is, where you project your own stuff onto the other person, something about you, something about the relationship in the community transference you project onto the other person. But projective identification is where you do it to the point where you get the other person to actually unconsciously start to feel like the thing that you're projecting on them. In other words, I project onto you that you're bad, you're a bad person, and you start feeling like I'm a bad person. That's projective identification. And again, that is something that is more common with personality disorders, but it also can happen with, normal people, neurotic people. And in this case, what this woman was doing was acting out this early relationship, or trying to, the behavior that she would try to get to have this relationship with this distant father. And the way that she could get his attention was by being sick, and and doing this kind of thing. So she was acting this out. Now, my job was to examine my countertransference. So I'm feeling annoyed by this woman. Why am I feeling annoyed? Where's this coming from? Like, some of it's projective identification. She's doing this because she's trying to recreate the situation from her early childhood. In other words, she's trying to recreate a father who is not giving her attention. So she's trying to drive away these male figures in her life, her boss, and then later on me, that's the therapist. She's trying to do these things she wants us to not give her attention unconsciously, because she's trying to recreate the relationship and then get mastery over it, right? So this is this repetition compulsion idea, which I think we talked about already, hopefully. But she's trying to do this. And so she's making me, the projective identification makes me not want to be around her. I want to reject her, right? And what I have to do, and as a therapist, to be the warm, neutral, consistent presence. Very important. You see how consistency is important here? That if I start like missing the sessions or rescheduling or whatever, because she's driving me nuts, that's going to just feed into her what she's unconsciously pulling for, the pathological pattern she's pulling for. It's going to feed into that. And then what she'll end up doing is saying, well, all men are rejecting, all men, do this. And, therefore I'm any relationship with any man is going to be terrible. I'm not even going to bother. I'm just going to go through a series of these bad relationships, because it'll fold over into the rest of her life too, like romantic relationships, work relationships, anything. And then, it becomes this thing of all men are bad, right? All men are terrible. All men do this, right? She'll just generalize to all men, and she'll just go through her life that way, being miserable, right? But if you're the consistent therapist, you're there every time, you're warmly neutral, you maintain that with her, eventually with her, I was able to interpret this stuff to her, what was going on. And she got it, and she was in therapy for a couple of years. I think she had 2 years, saw her 2 years, maybe a little more. And it was really interesting because you could see what had happened, especially group therapy, by the way, fantastic. Group therapy, you saw the changes in group therapy too, because she started, rather than competing with the other women in the group, she started making friendships with them, and they started going out together, doing things like, oh, that's a really big change, because before it was just this constant competitiveness, right? And so you see these changes start to happen over time. And then my countertransference is I would find her less annoying. You know, it became easier for me to be a warm, neutral presence with unconditional positive regard because she became a more pleasant person to be around because she stopped trying to recreate this pattern. She replaced it with a pattern of you know, consistent relationship with a male father figure kind of person, right? And her work situation got better, stopped bugging her boss, stopped calling in sick. And she was actually a very, very successful case. She did very, very well. And by the end of it, she would interpret herself. I wouldn't have to say anything. She'd go, oh yeah, I met this guy and I started doing the thing again, and I could say I was annoying him, and I realized I'm doing it again. So I stopped doing it, and then, you know, things went well, right? So that's the kind of thing you want to get. Does that make sense? Question?
I was just curious, when she was initially projecting, or recreating that dynamic, that she, you know.
Probably your whole life.
So do you think it was more of a, like, because it was familiar and a safe
Yeah,
pattern, or because
yeah.
she was trying to recreate it with hopes of altering it?
Both. So there's you know, we do these pathological patterns because we're used to them. It's the devil we know versus the devil we don't. So we just, you know, we keep doing these patterns over and over again. And then there also is usually, in a lot of times, there's usually an attempt at getting mastery over the situation by repeating it. This is what repetition compulsion is. I think we talked about that, right? Repetition compulsion, very, very important. This is where people repeat these things over and over again. You go, why is this person repeating this thing over and over again? It's obviously not serving them well. Well, the idea is they repeat it. The idea they recreate the pathology, and then they try to get mastery over it, right? And if they get mastery over it, then they fix it, right? But then problem is you never get mastery over it because you're just recreating it all over the place, right? This is very common in therapy, repetition compulsion. And you guys had, there's something in CBT, it's repetitive, the thoughts repeat or something. There's a word for it. You guys have something, there's something in there. I remember reading about it. I know schema therapy talks about maladaptive schemas. It's kind of the same thing, something like that. But this is the thing, this repetition that doesn't serve the person well. And it's very, very common. And then there's something that comes along with that sometimes called identification with the aggressor. This is kind of it's almost a repetition with compulsion with somebody who's been like abusive when you're a child, and then you take on the role of the abuser, you repeat it, but you've now taken on the role of the aggressor. And you know, that's another pattern. We don't have to go into that. That's in my new zombie paper, which is almost finished. I write about that because zombies are a good metaphor for that. One of the reasons why we like to watch zombie movies, it's identification with the aggressor. So anyway, I won't go into zombies. Get me off track here. You guys need a break? I see some glazing over. How about we go just a few more minutes and I'll give you a break. Okay. All right. Okay. So that's the case here. That was my case. I already said this, lots of different kinds of psychotherapy. There's always transference. It doesn't matter what kind of psychotherapy you do. And I talked to lots of CBT students who will tell me, I don't know why this patient came in and suddenly started screaming at me this session. They were so nice to me. They loved me so much before, and now they're screaming and yelling at me. What's going on? Like, what did I do? You know, well, that's transference, you know, positive and negative. Okay. All right. One of the things that we do in psychodynamic therapy, psychoanalytic therapy, is we help the person resolve these transference issues. And this is what the interpretation does. Helps them resolve, become aware of their transference issues, and they don't have to act out on them anymore. They have another model of relating to people, which is the way they relate to their therapist as a neutral, the therapist relating them as a neutral with unconditional positive regard. They can start using that as a model and relating to other people in the same way. And wouldn't we have a better world if everybody out in the world was able to relate to each other with unconditional positive regard, right? All you got to do is look on the news and just see how people are running countries and nations and interacting with each other, and where is the unconditional positive regard? It is nowhere to be seen anywhere. So that is one of the problems in the world today. And that's all I'll say about that. But I mean, that's if you're, Rogers, I think Rogers might have been trained as a psychoanalyst, but I mean, that's one thing that he coined that term, the unconditional positive regard. But that's that is the goal, to have unconditional positive regard for people. And so, as a therapist, you're modeling that. Okay, you're modeling that, even for difficult people. Okay. There's some idea that psychoanalysis, full-on psychoanalysis, 5 days a week, you'll completely resolve these transference issues. And in psychodynamic psychotherapy, psychoanalytic psychotherapy, you'll resolve them enough to get by in the world and change some patterns and be happy. I don't know. You say tomato, I say tomato, I mean, again, I just think the psychoanalysis prompt versus whatever you're doing it's just more intensity because you're doing it 5 days a week for a long period of time. So just more intensity. You can have more than one kind of transference. There can be more than one kind of pattern that needs to be resolved. Usually people come in and there's a main one that's really the thing that's causing them the most problems. But there can be other ones. And if you do full psychoanalysis ideas, maybe you'll resolve all of them. I don't know. Maybe not. I don't know. But anyway, there's some idea that, psychoanalysis, if you really need to resolve all of them, you got lots of bad ones. The full-on, more intensive therapy is better. And it's just basically saying that the more severe the problem, the more intensive the therapy you need, right? That should be obvious. Okay. Freud talked about this. I'll let you read this on your own. Okay. One of the things that we do in psychoanalytic therapy is to encourage what we call transference regression. And again, the analytic milieu, the scene, in the office can be where a place that can encourage the patient to re-experience these early childhood relationships, early relationship patterns with the analyst or the therapist. Okay. And typically non-psychoanalytic derived therapies do not work with the transference. And then because of this, they don't permanently help patients stop the use of these maladaptive patterns of relating as adult. It may be that CBT can help with maladaptive thought patterns that started in childhood. That's possible. But underlying those thought patterns in psychoanalytic view is those thought patterns were derived from emotional patterns. The emotional patterns came first. And then, so remember I said, CBT, cognitive behavior therapy, psychodynamic therapy, emotional cognitive behavioral therapy, that the emotional states come first. And so the idea is if you don't resolve the emotional aspects of this relationship, that the thought patterns won't get down to the root of it. Just talking about the thought patterns won't get down to the root of it. And that those emotional patterns will reoccur, and then whatever the thought pattern they'll have different maladaptive thought patterns. So the idea is you want to get down and deal with the emotional patterns. Many non-psychodynamic therapies give the patients the ability to repress their transference reactions. They just repress them. But the problem when they do that is that different things come up in their life, and these patterns will come back up again. It's like whack-a-mole. You'll get them here and then they'll pop up somewhere else, right? And then that's great for the therapist's bottom line because the person always needs to see a therapist. So you see them for a couple of sessions this year, they go off, they're happy, their symptoms are resolved. 8 months later, they have different symptoms, different problems, and they come back in again. Great for you, you get paid, you keep getting paid, but you're not actually curing the person. It'd be like if I was a physician and you came in with an infection and I gave you just enough antibiotic to suppress the infection, but it was still like under the surface, right? And then, okay, that's fine. Oh, you're well now, all your symptoms are gone. But, 3 months later, now your infection erupts again. You got to come back, and I give you just enough just to get it down so you don't notice it, but it's still there, right? Instead of, no, I'm a physician. My job is to cure you. We're going to get rid of the infection completely. We're going to make sure we're getting enough antibiotics that it's wiped out, right? That's the medical analogy to this. And I mean, I don't mean to be critical of other therapies because there's a lot of reasons why people can't come in and do psychodynamic long-term therapy. It may be that's all they only get 3 sessions from their insurance. So what are they going to do? They come in, they can do some CBT, right? Not going to get much out of psychodynamic therapy in 3 sessions, maybe a little bit, but not much, right? So you do some CBT or you do some other kind of therapy, behavior therapy, whatever. behavior modification and they get some symptom relief. But, you know, the underlying pattern is still there. It hasn't been dealt with. It hasn't been brought to consciousness. And so that's the difference. That's really the difference. My big thought now is that really there's no reason why therapists can't be doing both modalities. Person only gets 3 sessions. They come in, you do CBT with them, you get them some symptom resolution, they go off on their way, but then, you know, it's whack-a-mole, something comes up again, the unresolved pattern, they come back and they say, look, you know, you might be better off, we did something more long-term and try to get to the root of this, and they come in for therapy and they can do more long-term. There's no reason why these things should be mutually exclusive with one another. And unfortunately, out in the world, the CBT people, the psychoanalytic people, everybody's in their tribe, and they present the therapy they do is mutually exclusive with everybody else's kind of therapy. And that's just not really have anything to do with, in my opinion, have anything to do with reality. There's no reason why you can't do any of these, learn and do practice any of these kind of modalities, you know, depending on what your patient's situation is. And the book I'm working on now with my cousin is to look at how CBT therapists could actually integrate working with transference. And I think I told you guys this before, but, you know, I looked around for doing some research. Well, there's already therapies out there where they're trying to do this. They're trying to integrate CBT and psychodynamic therapies, a bunch of them. I had no idea, you know, and I'm learning about those. And so the idea is there a good model looking in these where CBT people can also incorporate working with emotional patterns, you know, as well as thought patterns. Maybe they work with thought patterns first and start introducing emotional patterns, you know, these kind of things, but also work with the transference, you know, acknowledge the transference. Maybe they don't have to go back into early childhood, but just acknowledge what's going on in the room as a repetitive relationship and something. And so we're working on that now and thinking about that. And I can't say I've come to any great grand, you know, thoughts or conclusions about it, but that's what we're trying to do in the book. And I think, I don't know why it wouldn't be possible, other than it just goes against what the tribes tell you. You have to, you know, oh, if you do this, you're not in the tribe anymore, you know, like, but I think we got to get out of our tribalism in psychology. Another dead horse I'll beat a lot. The tribalism is really hurting us as a profession. And what we want to do is we want to help our patients, you know, the best way we can, right? So what's their situation? What are they bringing to the table? What's going on? What do you recognize? If maybe you recognize they have a transference pattern with you, but you're only doing CBT for 5 sessions, 6 sessions, but you've been trained enough that you can recognize there's a transference thing going on. Then, you know, at the end of the 6 sessions, you could say, you know, great, you know, your symptoms are doing better. You know, if you want to learn more about yourself, because I perceive there's this pattern going on that might not be serving you very well, we could do some more therapy. And then you could transition into that, you know. So there's lots of options, lots of different ways you can work. And so one thing is I want to do is you guys will be the next generation. You're going to be the ones out there doing this stuff. And so one of the things I'm trying to instill in you guys is the idea that you don't have to be limited by, you know, by a certain kind of tribe or theory or thing. These things all can work quite well together. And the theories that underlie them can be quite compatible. Right. There's nothing inherently incompatible with CBT derived things and psychoanalytically derived things. There's some language differences. You know, there's a history, there's a contentious history which has to do with the MDs, psychoanalysts not allowing, you know, PhD people to practice for, I don't know, 50 years in this country. And, you know, that underlies a lot of this tribalism that we have. But we don't have that anymore. You know, all the PsyDs and PhD people can practice whatever we want now, and you can get trained in whatever you want. So time to just, you know, find, you know, take what's useful and do that. So I'll harp on that. I'll keep harping on it. Sorry, I'm just going to be repeating. Talk about repetition compulsion. I'm a walking repetition compulsion. Just going to tell you the same things over and over again until maybe some of it will stick. Okay. Let me give you another case example. This was a woman, this is part of a group therapy thing I was involved with. And the guy, the therapist who I worked with was a family therapist, and they saw the teenage daughter of a very prominent couple. By prominent, I mean the husband was a very highly placed film producer guy, very famous guy, very rich. And the mother basically was kind of a socialite character. Father traveled quite a bit, wasn't home much. Like the other case, when he was home, didn't give his children much attention. Mother was involved in social activities and very much had the vibe of having to keep up appearances, you know, be better than the neighbors, you know, that kind of thing. You use the wealth to let everybody know how wealthy they were, I guess. And she interacted with her children a lot to get them to mostly present the right image. Like the children had to be dressed a certain way. They had to, you know, give off the feeling that they were very wealthy. And the daughter, who's the oldest child, began to start acting out and rebel by using drugs and, you know, basically just acting out. And one thing is interesting when you work with, and I've not done a lot of couples work. It's not my thing, but one thing you notice when you do with families, couples with kids, is that when the kids, when the kids are the presenting problem and the parents bring the kids in my limited experience, you usually figure out right away why the kid is acting the way they do has something to do with the parents. And in this case, it was very obvious, you know, this girl was acting out because of the parents. So she took her father's Ferrari without his permission on a joyride and crashed it. Maybe crashed it on purpose. It was not a high-speed crash. And she was given the choice of going to therapy or being sent to a like a strict, like, you know, boarding school kind of thing, which she did not want to do. And the therapist, the family therapist colleague I had, very experienced guy, said, that's fine, you know, I'll see your daughter, but you know, you have to come into the sessions too. Made the parents come. And again, the therapist quickly realized it was the parents who had the really kind of serious psychological issues, and the daughter's acting out was a rational act. It was actually a rational attempt to get help. So sometimes the acting out can be, you know, that even though it seems kind of crazy, you know, driving a Ferrari into a tree or whatever, you know, actually it can be a rational underlying motivation for it. And that was the case in this thing. And over the year of therapy, the therapist became a very consistent parental object for the girl. And, you know, giving her consistent messages about like, and with adolescents, it's a little different. You guys maybe know better than me working with adolescents, a little different. You're a little more supportive, you know, you're a little more directive. And again, he was not a psychoanalytic therapist, he was a family therapist, and he was very consistent as a parental object, and he was encouraging this girl to go off to go to school, go to college. And the parents, of course, dropped out of therapy after the second session, so he just worked with the girl for over a year, and was a very good consistent object for her. She actually got her act together, got into college, went away to college, wanted to get away from the parents, went away to college, was able to live on her own, graduated from the university, got a job, but still reported that she had difficulty with some of her professors and some of her bosses at work. And it's a good example of how a non-analytic therapist can help a patient, you know, deal with some of the transference issues by being a consistent object. But since he was a family therapist, he wasn't interpreting them to her. So she never was really able to make those patterns really conscious. So in a way, she repressed these transference reactions. And then they came up again later in life, even though she was able to deal well symptomatically, you know, the underlying pattern was still coming up for her in her life. And, you know, probably eventually, you know, would probably require, you know, more therapy. And that's an example of transference repression. Okay. I talked about this already. Transference patterns related to the developmental stages. Okay. And I talked to you about corrective emotional experience. The transference patterns got to be corrective emotional experience. We talked about that. And now I think maybe I mentioned to you, but there's now some other therapies like schema therapy that are talking about corrective emotional experience, these combined CBT, cognitive therapies with psychoanalytic therapies like schema therapy. They're now talking about um, corrective emotional experiences. So you're seeing this coming up in other types of therapies. Interesting. And then, yeah, some interesting papers on that. The important thing to know is neutrality doesn't mean indifference. And so a lot of times neutrality was replaced behaviorally by psychoanalysts, especially in America, by kind of an indifference, just not even being there, sitting behind the patient on the couch, just not even being there. And that's really not what Freud was getting at. He used the German word indifference, not the German word for neutrality, and people mistook that. But he's very clear what he means by it. And he says he avoids turning the patient into our private property to decide his fate for him, to force our ideas on him, and with the pride of a creator, to form him in our own image and see that that is good. So what he means by neutrality is that you are not foisting your idea of who the patient should become onto them, but letting them instead discover who they are. And that's a very different thing. And this is one of the reasons I think why every once in a while, when you see lists of existential psychologists, you'll see Freud on the list, because this is a very existential statement. That you're not deciding somebody's fate for them. You're not making meaning for them. You're giving them the tools to be able to make meaning for themselves, to speak in the existential language. And that's very important. And this does not mean then that you are neutral, you're indifferent, where you don't say anything to the patient, or you're telling the patient who they should be or what they should do. Instead, you're doing something that's sort of a little bit in between, where you are still regarding the patient, you're behaving neutral toward them, but you have this unconditional, warm, positive regard for them as a human being. You have to have respect for them as a human being. And not trying to make them over in your own image is a version of that respect. Does that make sense? I think that idea that we're not making over the patient in our own image is pretty apparent in a lot of different kind of psychotherapies. I think probably in CBT, you're also probably not trying to make the patient over your own image. You are trying to get them to think good thoughts, but you're not trying to make them into somebody you think they should be. Am I right about that? You're not trying to say, really, you should be like this, right? You're not doing that. I think a lot of the modern therapies have eschewed this idea. There are therapies where, of course, you are telling the person what they should be and what they should do, these more advice-giving therapies, which I'm very much against. I think advice-giving doesn't work very well. And I think if you do give advice, it has to be very targeted and very specific and sparse, not doing it all the time. Because then also the person will become very reliant upon you for that. And that's another way you increase your bottom dollar as a therapist, that people come to you advice. But I think if you're going to give advice, then you, instead of becoming a therapist, you go into coaching, right? Coaches give advice. That's a big difference between coaching and therapy. Coaching gives advice. I know people who do coaching, and I've met a couple coaches, and what they do is something very different. They're helping people with strategies, usually for some specific thing. You want to make more money, you have a business, you're not making enough money, or you have a career, you're not making enough money, you want to make more money, and they will give you strategies. And it can be ways of thinking, it can be emotional patterns to adopt, things like that, but they're giving you strategies to change, that you can make the changes that you can then achieve some kind of goal. I think that's what most coach type people do. But it's a form of advice giving, but that shouldn't be confused with therapy, in my opinion. And that's just my opinion. You can take that with a grain of salt. That's just my thought. I think advice giving doesn't work very well. And I think most of the modern therapies pretty much have eschewed advice giving. I mean, in CBT, are you giving advice in CBT? I don't think so, right? You're just helping people to correct their thought patterns. DBT, you're not giving advice for sure, So I think in ACT, I don't think it's, except in commitment therapy, you're not giving people advice, right? So the modern therapies, people mostly realize advice giving doesn't work very well. Now, the coaching industry has become huge, and people like advice. People want to get advice, and your patients will ask you for advice. What should I do? And then you have to be able to respond to that and say, well, if I give you advice, how are you going to sort of figure that out for yourself? Say that in a nice way. I mean, so one of the things is I don't know if you guys have the experience of this, is I don't want to say dodging giving the advice. That sounds bad, but turning the advice requesting question back into therapy. And in psychoanalytic therapy, we do it through the things we just talked about, through transference. It's interesting you're asking me for advice. I'm just wondering if that's, what your experience with people giving you advice is, turning it back on them without breaking character and giving them advice, right? So that's, and different therapists have different levels that they'll do that. I think I write in the book, my supervisor, who's an analyst, he was in analysis for like 8 years. And in like 8 years of analysis, the only time he ever got advice, he was just sitting free associate on the couch, just going, oh God, I got to get a new car. I don't know what car to get. And he's heard this disembodied voice behind him, analyst. Analyst said like one sentence, I heard Hondas are good cars. That was the only advice he got in 8 years of 5-day-a-week therapy. I mean, that's a real hardcore analysis, no advice giving, right? You don't give people advice. And even that, probably the analyst probably went home and thought, oh, that was a therapeutic mistake. I mean, so advice giving, you have to be very careful. Now, on there, I'm not discouraging you from having a coaching practice too, because you can make a ton of money as a coach, and, there's nothing wrong with doing that. Just keep it separate from your psychotherapy practice. In your mind, at least, have these separate things that you're doing with separate kinds of goals, because they're really different. And advice giving, I don't think works well for psychopathology. It's just my opinion. And maybe your other professors will tell you different, but I'm thinking since the modern therapies don't use it, probably you're okay not using it. Some of the humanistic therapies can have some advice giving. There can be some advice giving subtly. Gestalt therapy can subtly give you advice when the therapist is yelling at you that you're a fuck up or whatever. There can be subtle ways of giving advice without directly giving advice. And again, psychodynamic therapies try to not do that. We don't want to subtly manipulate the patients. We're not trying to be manipulative, either. And we're not trying to direct them or be manipulative. We're trying to let them discover who they are and figure out the best person they can be. But they got to figure it out. We're just there to catalyze that happening. Okay. All right. So that's really what neutrality is about. Anna Freud described it as being equidistance between id, ego, and superego, something in between all those things, which may make sense or may not make sense. Some days it makes sense to me, and some days it doesn't make any sense. But if that helps you, then that's what Anna Freud said to do. Okay, we talked about countertransference already. Dar talked about it in the paper, and that's the therapist's unresolved stuff that then gets triggered by the patient, and they play out with the patient. If you are experiencing countertransference, the idea is you got to remain neutral still. And if you are experiencing countertransference and you're not quite sure where it comes from, that is your cue to go get some consultation with that client, or maybe you need some more therapy yourself. Maybe you got a blind spot that's being triggered that you didn't realize you had. Maybe you get more therapy. A lot of times, I think I said this, the consultations you get with your, for supervision or whatever, a lot of times those can be kind of therapeutic, somebody, a colleague, a more senior colleague may be able to see something going on with you that you're not aware of and point that out. And that can be a therapeutic thing. Maybe that helps you realize something that you knew before, or maybe it helps you get the impetus to go back into therapy, or maybe it just helps you with that client. But getting consultation is super important. And I'm a big believer that therapists should get consultation throughout their professional careers. We all have blind spots. We're not perfect. We're not perfect beings. We all have problems. We never, unless maybe you've been through an intensive analysis, you probably haven't resolved all your transference issues. So they're going to come up. And even if you have been through intensive analysis and you resolve all your transference issues, there's no guarantee they won't come up. Some of them won't come up again. So, you can get triggered by patients. for various reasons. You know, their personality somehow meshes with yours in a way that triggers you. And so consultation is really, really fantastic. And I would encourage everybody to think about that. You know, keep getting consultation. Right? Nothing wrong about that. Shouldn't feel ashamed or less than because you felt you needed to get the consultation. And I've known many experienced therapists who've gotten consultation through their whole careers, and, you know, absolutely nothing wrong with that. Okay, neutrality. Again, we talked about that. Non-judgmental therapist. You refrain from expressing judgments of right or wrong, even not through just the words, but also through your behavior, even your body language. You have to be very careful. This is another reason why, you know, the analysts like the patients facing away from them. They're not reading the body language of the patient, because sometimes you could be very neutral in what you say, but your body language is expressing something. Like maybe the patients tell me something, I'm very neutral in what I say to them, but then I'm sitting there like this. You know, well, if they're facing me, they pick up on that, right? And now the converse is also true. You should also be reading the body language of your patients, you know, for the transference reactions. You can do that. But traditionally, analysis, patient is on the couch, you're behind them or to the side of them. They're not seeing your reactions. And so this is something that can help the neutrality. Not that you can't do it with chairs face to face or the chairs slightly facing away. That's perfectly okay to do too. You just have to be aware of it, your body language, you know. And sometimes your patients will call you on it. I had patients call me, I'm like, you know, I do something like this. They call me, I wonder why are you crossing your arms? Is that like what I said? Oh, you know, tell me, you know, what that feels like, you know, have to get back into their feelings, you know, let's get away from me. Who cares about me? And sometimes the patients will ask you over and over and over about you to share something about your life or something. And that can also be a transference reaction where they're trying to break you out of the neutrality. And, you know, my common thing that I would say would be like, you know, we're really, you know, you're paying money for the session. This session is about you. You know, we really should stick with what's going on with you. You know, some variation thereof of that kind of statement. And because your patients will try to get you to talk about yourself and your life, and they'll be curious about you. And some borderline patients will stalk you a little bit, and you have to learn to deal with that and maintain neutrality. And there are points where, especially with personality disorder patients, where you in a way break neutrality because you've set up a boundary that can't be crossed. You know, look, if you're going to call me on the phone every night and try to talk to me every night, you know, like, and you'll yell at me on the phone, leave me a message every night, yelling at the phone, we're not going to be able to do therapy, you know, and I'm here to try to help you. But if you cross these boundaries, I'm not going to be able to help you, and then you're not going to be able to get the help you need, you know, and really what we're here to do is to try to help you with this thing that's really bothering you. And that's what I really want to do. And to do that, we have to maintain these boundaries, something along those lines. You know, and, you know, I found that at least most of the people I saw, they seem to get that after a bit, you know, and there'd be a little testing every now and then, but they seem to get that. Okay. So I think that's all I really need to say about that. Don't impose your values on the patient. Very existential. Don't impose your values on the patient. Don't make meaning for them. Okay. This is a good cartoon for countertransference. I'm not clear how it's my neurosis is your parents' fault. So get it? Takes a second. All right. Okay, so this is what I wanted to end this lecture with. This is what happens when your countertransference goes awry. The Board of Psychology prints out a letter. When you're licensed, you will get this letter. I don't know, maybe you're getting it already. They print out a quarterly newsletter, and the back pages is basically, you know, the walk of shame. It's like you know, Game of Thrones, when Cersei has to walk and there's shame, right? And they're ringing the bell, they parade her through town. This is the psychology equivalent of that. This is the back of the thing. These are all countertransference people. I just picked, this is from 2022, you know, I just picked these out, and you can see these things in here: gross negligence, repeated active negligence, violation of rules of professional conduct, try to facilitate a romantic relationship by introducing the patient to a formal relationship. This woman got, she got countertransference into like being a yinta, to like being a matchmaker, so some patient pulled for some transference to get her to be a matchmaker for her. Again, if you're a coach, you probably could do that. You could be a matchmaker coach, right? All those, you guys watch those matchmaker TV shows? Oh my God, they're fantastic. I mean, this is like a psychology lab, and then they always bring in the therapist, right? And the therapist is all some kind of unlicensed coach person who comes in like, oh, and I'm thinking like, oh man, like, my students at CLU could all do like 10 times better job than this person. Like they have no idea what they're talking about. They're making up some BS. Like you guys are doing 10 times better, and, but this is, this psychologist, somehow that got her countertransference got pulled in, and this was she's doing, or getting into a business relationship with your patients and this kind of thing. And this gets into the craziness. And this other guy, and then the other guy is the sexual exploitation, sexual abuse, misconduct. Usually the sexual interactions with the patients, usually this is related to countertransference, unless the psychologist is just clearly a sociopath. Then they're just going to try to get away with whatever they're going to get away with. But if not, you can guess it's some kind of countertransference going on, probably positive countertransference, unless the guy's a masochist. We don't know. But anyway, you don't want to end up on this page of disciplinary actions. This is a drag. They will, they can yank your license. The Board of Psychology, I'm going to turn the thing off to say this. Because I don't want any of your professors, they might take offense at this. The Board of Psychology, they're not very friendly. They're not your friend. They're out there. They've made their thing not to be helpful to psychologists, people with the license of psychology, so the psychology license. Their job is they think is to protect the consumers. So they're a little overzealous in going after what they perceive are infractions that you might make. So not that these ones are not really infractions. These are pretty bad countertransference things that go on, but the board's not really your friend. And so they will go after you for even some relatively minor things. So you have to be very careful about like making sure you have insurance, that covers all sorts of things. And just remember, they're not your friend. That would be my advice. I don't know. I was thinking of getting licensed in Oregon, and I called the Oregon Board of Psychology, and they picked the phone up and they talked to me, and they were just the nicest, most helpful people. I'm like, oh my God, I can't believe you guys are the Board of Psychology. They go, oh yeah, we're trying to help you. Like, like, wow, like that's very different than California. Like, it's like I was shocked. It was like, I just want to get my license in Oregon just so I can have a license with nice people, like instead of these horrible people here, but they take consumer protection very seriously. So you have to be aware of that, right? You got to be a little cognizant of that.